Okay, so we'd like to welcome Dr. Bragee. Is that correct? Today, we were very excited to have him here. He's a specialist in anesthesiology, intensive care, and pain medicine. He works at multiple locations, including the Bragee Clinics, a rehab facility for multidimensional diseases like severe chronic pain, exhaustion syndrome, or MECFS, and the Division of Family Medicine and Primary Care. And he is going to be discussing his breakthrough study that we know it is today, and we're just very happy to have him here. Thank you so much.
Thank you for that introduction. Nice to meet all our friends all over the world and health professionals engaged in this disease. So I have a PowerPoint that I will start with, and I'm not critical if you interrupt me. It's absolutely okay if you have any questions or comments. Nu ska vi se, yes, there, share screen, and there you are, and from start. I call this a midsummer dream. Mad dream, maybe. And it's really work not only from me, but from several co-authors, and not at least Dr. Bo Bertilsson, who is my friend and research leader at the clinic. Just a few words on the settings. We have a ME clinic, maybe one of the largest or largest. It's a private clinic within the regional county health care, so the patient are reimbursed by the county health care. We have 40 professionals at this clinic, amongst them 14 MDs, most of them specialists, all of them specialists, and many of them also PhDs or professors. We get about 200 referrals per month, and we have now around 2,000 patients with established diagnosis of MECFS. We are sort of a national center. We are the only running clinic for the moment, but there are 1 or 2 or 3 clinics that will start in the autumn. And we have also some good research resources and experiences. We are a unit within a larger rehab center, a multimodal rehab center for pain and exhaustion syndromes, burned out syndromes, you would call them, where we work with 9 to 10 weeks program in a multi-professional way. It could be interesting to see what kind of professions we are focusing on. Physicians, of course, 8 psychologists, 16 physiotherapists, 8 occupational therapists, and 6 social workers, 2 dietitians, and 8 registered nurses. We think physiotherapists and the health professionals, besides the physicians, are very important, both in MECFS, pain, and exhaustion syndromes. We really work very team-oriented. All patients meet us in team-wise. For me, this is me and my wife and some patients. My wife is a physiotherapist too, and with a PhD in the field, and which I haven't reached so far, but I am a specialist in anesthesiology, intensive care, and pain medicine, and a founder of the clinics. And my research work is in cooperation with others at the Karolinska Institutet, that's a large medical university in Sweden. We focus a lot on education, both for patients and the community. This is a picture from a series on Swedish national television that we made on ME, on research in MECFS. Besides all the time, besides these times with Corona, there have been a lot of seminars, both for patients and a cooperation with the patient organizations too. I won't go in deep on ME, as I understand that you are all well aware, even sufferers or having friends or nearby suffering from the disorder. But I can say just a few words as you record it, that this is, we are using these are the international consensus criteria, that is a post-exertional neuroimmune exhaustion compulsory. There are neurological impairments. That's very important for us, both neurocognitive and pain, for course, headaches, widespread pain, sleep disturbances, and motor disturbances and neurosensory disturbances. There are also immune, gastrointestinal, and genitourinary impairments, and energy production, transportation impairments. It's another field in our research. We are having 2 studies just now that are on mitochondrial effects in the disorder. The prevalence in Sweden are said to be 0.4, but that's really just a reflection of what you have found in the United States and England. And it might be larger, of course, not at least after this pandemic virus situation. We don't know really, there are no consensus, but there are a lot of evidence or on different perspectives of what is behind the disorder. We haven't found any specific infectious agent. There have been some reports, but they have failed to be reassured. The present hypotheses are that, for me, I think it's a paraviral trauma. It's very often they are starting with a virus infection, but it's not an ongoing virus as far as we know. They are just making a study that might turn that thought upside down. Of course, there are genetic influence and immunological explanation as well, and neuroinflammation is sort of a umbrella for many symptoms of the disorder. And the mitochondrial dysfunction hypothesis. R is more that this is a neurological disorder with the brain in focus, and it might also be an intracranial hypertension. Some words on our center. All patients have severe or very severe ME. A lot of the patients are homebound. We have 3 cars just running around Stockholm and the adjacent regions to meet the patient at home. At least 7 to 10 visits a day we do. And we also have every third of our patients are from other regions in the country. They have a very low quality of life. We have compared with the studies from other, well, there have been some publications on the quality of life with ME, and it's said or shown to be lower than even cancer or depression and other major disorders. The lowest of all studied groups, a study from Denmark. Our patients are even lower. They have a medium declared quality of life less than 25%. It's very low. And a lot of patients do really say, I had better be dead. I have a life quality lower than 0. That's a challenge, of course, but at the same time, it's also, you can be lucky to working with these patients because only the good care and knowledge and education and trust will help the patients. We have a sort of a underlining that say, be safe and feel trust. That's a good, and hope. It's a good start for all care in this disorder. After 40 years or so in pain world, I have 3 major conclusions. First of, when I educate young colleagues or at the institute and so on, I say, examine your patients. That's very important. Take off the clothes of the patient or let him have not being naked, but at least so you can examine all joints and all back and so on. Use discomfort drawings. I will come back to that. And trust both your senses and your patients. What you see and what you feel is most often right. The zebra you know about. It's a saying, I guess you are familiar with the EDS society that has a zebra as a token. You know the story about that, Melinda? And yes.
Yes,
Uh,
yes,
I think it's something you heard when you become a doctor. Don't look for zebras. I think that's the opposite what we should do. Look for
exactly.
Yeah, definitely.
Anyhow, we have a patient register now about 2,000 diagnosed patients. We have diagnosed them with the Canadian consensus criteria as we find them the most narrowing criteria. And we have a rather large database of all our inquiries and so on, discomfort drawings, EQ5D, that is quality of life, physical, including neuro exams, Bayton scores, a lot of lab and MRI tests and so on, together in a very large database for the clinic. And here you see a discomfort drawing. Why do we not say pain drawing? That's the most often used name of these sketches. Well, if you say to a patient, please sketch your pain, they often forgot areas of numbness, which is as important. So it's better to say discomfort. Oh, this is the low life quality. It was in Swedish, so I jumped to next one. So we think it's obligatory to make bedside exams, full body status, neurological status. Every patient should have tested their sensibility for pinprick, touch, vibration, and also QST, that is quantitative sensory testing. I will come back to that. They should be tested for strength, gait, balance, and autonomic reaction to upright position. And we shall do mobility and joint tests for all patients that are judged having or not having MECFS. And this study is sort of a reflection of that. A discomfort drawing can give you a diagnosis that is as accurate as an MRI within 30 seconds. And it's of course much cheaper. And you can compare that to the status that you have just performed for the patient. And you can really see that this patient, for example, has a combination of widespread pain, like in fibromyalgia, and some neurological, for example, in the left part of the neck, and also in the legs, that indicate neurological problems. I don't know if you use them a lot in the United States.
I think most people use them, but unfortunately, they narrow it down to pain and would freak out if somebody presents this level of detail.
Yep. I think it's important to be not to be too informative to the patient, but let the patient decide how this gets. And use a soft pencil is also very important, not just a ball or pen or so. Okay, neurological exam is not important, it's imperative. Do the patient have sensory aberrations? Does she has hyperesthesia, feel numbness? I think the instrument you can see here is one of the most important. It's a spur, and you can take that to very rapidly go through different segments from the neck or the back. And another important testing in MECFS is the discomfort or the pain changed by traction or compression. It's a very simple and elusive test, compression and traction. It should only be made by trained professionals that really knows what they are doing, because it's not, it has some risks if you are too brisky. It has to be very gentle and mild. And the patients, they can report directly any relief or worsening of symptoms. And it's very, very often that these patients, they feel some relief when you lift their head very gentle, indicating there might be some problems in the craniocervical area or the upper neck part of the body. And if she is better with lifting the head or get worse by light compression, they can use an inflatable cervical collar, not the day around or so, but for critical moments like going to the doctor or going out and so on. And they like it very much. We give them free of charge. They are not, if you buy them in China, they cost only a few bucks. Physical exams is so important. And both Bo and I are educating students at the Institute just before they leave out to be doctors in real life. And we are every time as astonished how little they have learned during these 5 years. They don't know how to make reflexes or sensory testing. So we teach them that. And it takes a minute to learn and a lifetime to master, like Othello. Third, trust your senses as well as your patients. Believe your patients with all their odd symptoms. It seems odd to have to stress that. But if you do that, you can see a whole new world open up for your eyes as a health professionals. It's like comparing just looking on a tree that might be affected by any disease or disorder and go through a wood. If you meet a lot of patients, totally another picture will show up for you. After some 100 patients or so, it's obvious for any thinking or professional person that this is not a primarily culture disorder. It's not primarily a social construction. There's still a debate in Sweden, as well as it is for COVID, post-COVID, that this is not a, it's a medical unexplained disorder of social or cultural origin. And it's not primarily psychological. It's primarily a neurological disorder, and it's secondarily a musculoskeletal disorder. But most of all, it's a brain and plasticity syndrome, engaging brain and plasticity. So I jump into the article we wrote a year ago. It has been very spread amongst patients, and it's really been the most viewed article in that paper's history. Not so much amongst the research community so far, but there are coming more and more citations and so on. Maybe it's turning things upside down a little bit too much. This was a result that after 200 patients, we said, we have been walking through the wood and we could see this new picture. Shouldn't we describe what we can see? How come that so many patients are hypermobile? So many patients have neurological deficits, and it's never been described in their journals. So we took our first 279 patients, and 229 of them gave an informed consent. And most of them were women, of course, and the median age in our group is around 45 years. Interesting enough, we also have good numbers on the patient's social strata and education and so on, and they rather belong to the higher social strata and education. They're very often professionals of different kinds or university educated and so on. So this is not patients that has not sought care. So even so, the time since onset have been 8.8 years before they come even to the clinic. And the number of different diagnoses the last 5 years is 22. that number is now rising because we could only see in Stockholm, we have a common computer system for all clinics. So we could see in the medical journal from other clinics what they have been through. But now we have just got access to all databases for medical care in the region, county. And then it's even more. It's not only 22, it might be 30 different diagnoses. And the number of care contacts is very high, even though many of these patients are so sick that they can't seek care. So they seek care and they get a lot of diagnoses, but only less than 15% of our patients had had any idea or diagnosis of ME before. You hear me clear?
Yes.
Good.
And we have Leanne has joined us. She had some trouble with the link, but she's an occupational therapist that has joined us.
Good. A very important health professional group in the care of ME patients. I say something on hypermobility. We use the Baton scale, of course. And you are familiar with that, how you count points?
Yes.
Depending on patients' ability to move different joints. 41% of our patients were hypermobile. That's a lot more than expected, I can say. Why is the expected rate is only 2-3% or so? And being hypermobile means that you have a variant of the most common protein in body, that is collagen. And we don't say we say it's just a disturbed variant, especially in the three most important types of 1, 3, and 5. And one should know that collagen is in all tissues in body, connective tissue itself, ligaments, vessels, cartilage, bowels, and so forth. So there's no, if you have a group with many patients with collagen disturbances, you can be sure that they have a lot of peculiar or unexpected findings in the body. And hypermobility per se, that is in itself, gives also a lot of symptoms: dislocation, pain, widespread pain, bruises, bleeding, high heart frequency when you raise up, dysautonomic symptoms. And interesting enough, just having hypermobility gives you a high degree of tiredness, both muscular, because you have to use your muscles all around the day to keep your body in order, and general fatigue. And we use the 5 questions that you use on hypermobility syndromes. That is, have you been able to bend forward with straight knees and reach the floor with flat hands? And it's impressive seeing these ladies in their 50 plus doing that, and no one has never told them that this is not normal. Or can you now or before bend your thumb down to the forearm? And as a child, could you amuse your friends? We call it, did you have funny party tricks with showing odd positions or doing the splits without training? As a child or teenager, did it happen more than once that your patella or shoulder dislocated? And do you regard yourself as hypermobile? 5 easy questions. Together with the exam, it takes 2 minutes to establish the diagnosis. And it's so shameful that this is not been made before. I cannot understand it. Yeah, it's unbelievable, really. When we get young students to us and we show this, they say, we have never seen that before. But are there even more common findings? Yes, there are. We make something that we call a quantitative sensory testing of pain threshold for pressure. We use an electronic device. You can use your thumb. If you use your thumb and you press it until it whitens a bit under the nail, you have pressed it with 4 kilograms per square centimeter. And that should not provocate any pain normally. But if it does, if we feel even the slightest pain lower with a lower pressure, you have something called allodynia or an abnormal. It's a pain from an usually harmless stimulus. And this is a sign of nosoplastic pain. You can see one of our staff here testing that on the forearm for a patient. With this instrument, we can gather everything electronically, but the thumb is a good alternative. And then we found that 96% of these 229 patients had low pain threshold. They were sensitized using the same protocol as we do for fibromyalgia. We don't say they have fibromyalgia because that is something, there are some other criteria for that too, but they are sensitized. They have widespread pain. This is a neurological disorder. It's not a neurological design. It's something abnormal. And there's a thoughtful comparison here between MECFS, EDS, that Ehlers-Danlos syndrome, and hypermobility spectrum disorders. That's a new name for hypermobility disorders. In ME, hypermobility is common. In EDS and HSD is obligatory, of course. Pain is obligatory in all of these patients. 3 patient groups have pain. Joint injuries are, most patients with EDS have joint injuries, some with MECFS and many with HSD. Tiredness, very common. Of course, all with ME have tiredness, but most patients with EDS and HSD also have tiredness. PEM, it's a bit surprising, most of patients with EDS and HSD, they complain of post-exertional malaise. Vertigo and dizziness, well, most of patients with ME, many with EDS and some with HSD, like dysautonomia, same picture. POTS, many patients with MECFS have the tendency of a heart rushing away when they are going up from the chair or bed. And so it is in the hypermobility syndromes too. The prevalence, well, these can show that MECFS is 20 times as usual as EDS, but only HSD is much more common, of course. Anyhow, you can see that there's no, these are common disorders. Then every doctor meets them sometimes. Every practitioner meets them many times. So if we took all the criteria for fibromyalgia, 76% patients with MECFS fulfilled the fibromyalgia criteria. And as I said before, the 76% is the deep purple. Then we have some patients with lowered threshold but not fulfilling the criteria. Only 4% are normal, so to say. When I started in this clinic in 2017, as a pain doctor, I have met a lot of patients with EDS and MECFS during the years, but one at a time, maybe once a week or once a month a patient. And so you didn't get the whole picture. Suddenly, I met a lot of female patients with MECFS, and very many of them said that they had been horse girls. They had been riding or having horses. So I thought, is this a virus from horses, or what is going on? Until I understood what really it was. You understand? You do, eh? Contact sports, both in females and males. So I had to reconsider. If you have loose ligaments and pain sensitization and a physical trauma, the consequences can be dramatic. We everyone say that 80 to 90% of the patients with MECFS has the genesis, the history depends on virus infection. We make the same. Every patient is judged what we think as a doctor is the primary cause, and then cervical syndrome is not too seldom, and hypermobility is even more common. Infection, that is, I mean, every patient has had an infection because we all have infections once a year or so. But here we restrict us to an infection that the patient was healthy before and get an infection that is known, and after that has been ill. That's another thing that I have. Oh, I have had Borrelia. I have had Epstein-Barr viruses before. Stress, not too uncommon. Vaccination, not common at all. This is, of course, not any proof of the origin. It's just the doctor's view of what is behind. It's also very common with discoligamental injuries in neck area. 80% of the patients do show such findings. There's a large overpresentation, especially in younger patients. When you get older, most of our patients and the general population have these changes, but it's a large overrepresentation. And different Chiari variations, that is a low position of the cerebellar tonsils. The cerebellar tonsils should not intrude the foramen here, that is the hole where all vessels and nerves are going up to the brain. It should not take place there, but if it does, maybe due to high intracranial pressure or genetics or other reasons, then you get a disturbed CSF flow. And we found that at 3 times or 5 times more often in ME patients than what could be expected in normal patients. And 43% of the patients had these signs of low position cerebellar tonsils, which then compromise the area where all nerves to the brain and the CSF flow is going through, and also vessels. And we also made a lot of other findings. So I will take some of them here. In 115 of these patients had neck problems and been diagnosed with MRI neck. And we looked for different kinds of obstruction: osteophytes, pinched nerves, herniated disc, old disc, and so on. Everything that could compromise the area for the free flow of cerebrospinal fluid. And we could find obstructions in not less than 71% of the patients. And a medulla impression, that is a more severe obstruction in 26% of the patients, and some other signs also. So that obstruction of different kinds are very common too. Surprisingly, no one has ever discussed these findings, even though the patient has really told the doctors they have met that they have different kinds of numbness or pringling or tingling or pain in the arms or in the neck or headache and so on. We also looked for the clivo-axial angle, which is a sign that could lead to this less area for the free flow of cerebrospinal fluid. And it was also surprisingly often compromised or too high. What is this? This is an astronaut.
Dr. Bragee,
Mm-hmm.
may I ask you a question about that previous slide?
Sure.
Did you measure any of the other angles? Like the grab oaks or
No,
the,
we did
okay.
not. We did not. Um, we could have done that if we have understood from the start what we were going to look for.
Right.
That's fine. So we will do that. That's the next study.
Okay.
Mm.
That's what I was curious about.
Mm-hmm. What does this astronaut do? He's measuring his intracranial pressure, because that is a potential problem when you're in the weightless state in the space, and he's using a ultrasonic device, because the eye is an integrated part of the brain. Both brain and optical nerve is surrounded by the same sheath, not sheath, and intracranial fluid. So if there is a higher pressure in the brain, it will also affect the optic nerve. And you can estimate the intracranial pressure with the measurement of the widening of the optical nerve, because the sheath that is surrounding the nerve is expanding if you have a high intracranial pressure. So it's a very easy thing to do with MRI pictures. You can also use ultrasonic device. But if you have already made an MRI, you can easily afterwards just take a measurement, how wide is the nerve, and see if there is, and look upon that as a sign of potential high intracranial and pressure. And it gets even more obvious if you relate to the size of the eyeball. I mean, some of these studies are made on patients from Korea and Japan and so on, and to presume that they have the same eyeball diameter than a tall Swede is a bit uncertain. So if you relate it to the size of the eye too, it's get even more obvious that many of our patients have signs of a high intracranial pressure in this aspect. Really 83% if you just decide to measure on one side. If you decide to measure on both sides, it's a lower frequency, but it's still a surprisingly high frequency. And this is a sign that is used within the intensive care as a routine examination for early detection of high intracranial pressure. And you can also use ultrasonic device, and that is a study we will start with in August. It's a cheaper and more rapid method. Can you be made at the clinic instead of getting the patient into a magnetic resonance chamber. And if you have an increased pressure, it leads to inflammation. You can see it in the eyes, but you can also see it on different signs in the MRIs that you get. Many patients with ME have small areas with white spots. That is a sign of previous inflammation. What would be expected if we have a higher intracranial pressure? We could expect that the patient had blurred vision. Is that something you have heard about in the ME world? Headache, not too uncommon. Brain fog, vertigo, dizziness, tiredness, exhaustion. There has been a article in the Swedish Medical Journal just recently, last year or so, where they examined patients with so-called idiopathic intracranial hypertension, and they could find that daily headache they find in 84% of the patients. That is one of the main complaints in with our patients at the ME Center. They also show sign of something patients do not report spontaneously, but if you ask them, they have reports on that. They get short episodes of vision loss. The vision seems to vanish for a second or so. Back pain, that's a rather unexpected finding from intracranial pressure. A very common finding amongst our patients. Neck pain, pulsating tinnitus, vertigo, light sensitivity, reduced vision, double vision. These are signs that is also common within both MECFS as fibromyalgia and other disorders of central nervous system problems. And it might be a reflex of high intracranial pressure. There have been some, after the publication of this study, there's been some new studies that seems to confirm at least some of our findings. For example, from Jessica Eccles in England, that described the relevance of hypermobility, fibromyalgia, as well as MECFS. So my conclusion: different obstructions in neck and cervical cranial junction might be more common than expected in MECFS. Intracranial hypertension can be suspected in a group of patients with MECFS. Such hypertension might lead to inflammation in central nervous system, and collagen dysfunction might contribute to both obstruction and leakage of central spinal fluid. It's a D there, I can see. And it's need to be tested in further studies. Just a few words on the collagen dysfunction here. If you have a not too tight connective tissue, it also is not as tight in the central nervous canal or in the vessels, and it can lead to a lot of leakage that is unexpected and give problems. There are a lot of different disorders here, but for me it can be that MECFS is sort of a center of many different disorders that have some common symptoms and maybe have some common background too, and also, of course, new common treatments. Post-COVID is a new circle here. Some of the patients with MECFS seem to have rather severe post-COVID. Burned out syndrome. So an MECFS is sort of a center in a lot of disorders, and maybe that's a reason that's so severe. And we can also, we do believe that there are groups within the MECFS community or patient groups with different origin, but more or less the same picture, the same symptoms. And of course, we don't deny there could be a lot of complicating factors here, from depression, socioeconomic stress, post-traumatic influences, and anxiety, and so on. One should not throw out the baby with the bathwater. We have a psychologist at MECFS. Not that we believe that MECFS is of psychological origin, but it certainly have a lot of psychological consequences. So I think it's a word of zebras rather than a word of horses here. And that we doctors and health professionals, like both physiotherapists, occupational therapists, psychologists, and so on, should have our eyes wide open to see and note and believe the patient's description of his symptoms. It's gold mine of knowledge in the patient world. So that's what I had to say now. So I give a word to you for questions.
Break up.
Oh,
That was awesome.
Absolutely.
Yeah. I was wondering if you could tell us how your physios have been used and your OTs prior to the study as part of the health team, and then is there anything about this study that changed how they are utilized?
I think we lost him. Did we? No.
Are you there, Dr. Bragee?
Everyone disappeared.
Yeah.
Here I am again.
There you go. That was wonderful. Really.
Absolutely.
Yeah.
Hmm?
I was wondering if you could tell us how your physios and your OTs used in your facility prior to the study, and if there were any changes in how they were utilized in the healthcare
Oi,
after this study.
I think I have to. You asked me, as I understand, how our physios and occupational therapists works.
Yes. Mhm.
There's something with the connection here. I think I take my computer just a few meters away
Okay.
to get a better connection. Now, I guess it's better. You asked if how they work. The
Yeah,
first thing is to establish. First step for the.
Were there
First
any
step for the-
changes too that you had that occurred in how you used them pre this study, and then did any changes occur in how you utilized after this study?
Well, really not. We are still focusing on diagnosis and not on treatment in this area. And one of our physiotherapists are in the final of her dissertation on these findings. So she mainly works with diagnosing still. And we have already from the beginning have a focus on helping patients with blocks for cervical, as anesthesia blocks for cervical problems, and neck collars of different kinds, and relevant training and so on. So I don't think it's changed a lot, because I mean, this is just because we have written an article, we have seen this for a longer time than that. The first step for a physiotherapist is to establish rapport with the patient. They have a genuine fear or distrust in physiotherapists.
Absolutely. Because they've been harmed in the past.
Yeah, so the first step for them is to establish rapport and see that they're not going to train harder or just focus on that side of the thing. For our occupational therapists, home visits are very important, because we can offer a lot of help in the home with different kinds of different kinds of what do you say? New
Adaptation.
bathrooms, taking away
Mhm.
stairs and so on. Yeah. So they are making a tremendous work in helping the patients with the environment at home. And of course, both these working professionals are health professional groups are also giving lecture on pacing, and they meet a lot of relatives. We have a lot of information for relatives too, not at least by when we have children. And also a major task for both groups are describing the functional status of the patients for insurance for the stately insurance. So they have a sort of more objective picture of what the patient can or not can. And that is a very hard task. I guess it's about the same everywhere. They are met with distrust from the insurance. We have a stately insurance, but regardless of what authority is behind the the sick leave compensation, I guess it's a major question for them that the patient they meet seems fairly fairly healthy, and also honestly say that yes, I can take a walk, and then but the price is too high, and that is a matter that the insurance authority don't accept.
Mm.
So it's important to use the ICF, the International Classification of Function, and make thorough, semi-objective and objective exams of the patient.
Were you noticing any sound sensitivity for in your study? You talked about hearing, sound sensitivity.
Yeah, not in our study, but it's something that is reported very often by the patient, that they have a sensitivity all kind of stimuli.
And like
not on vision, hearing.
when you were talking about the optic pressure and having headaches from that, where were the headaches? Where were they people pointing to headaches? Like
mostly neck pain, really, in the back and back head more than often, but many also behind the eyes and so on.
Right.
Okay, good. Okay, thank you. And do you see the MRI, like being able to look at I think it was a cerebellar tonsil, as a diagnostic tool to see where that has?
We are very, it's important not to over interpret the findings, because any treatment can be it's a major trauma to undergo surgery, and so it's really important that you don't exaggerate the findings. A few patients do have true Chiari syndromes and should have surgery, but there are very few. Many of our patients are referred to orthopedic surgeons. The problem is that most of the orthopedic surgeons, they are taking the patients, they don't want to make surgery on patients with MECFS. So we lack educated staff of spinal and neck surgeons. We have some good colleagues, but they are very conservative. It should be. I think it's good to be conservative.
What about when you're describing your relationship with the state funding for the healthcare, the state insurance? Oh gosh, they're working on my house. It gets noisy. Does your organization have difficulty finding ways to demonstrate progress with the ME people? What we see and hear a lot of times is that, a therapist can take in an MECFS patient and work with them for a brief period of time, but they can't extend therapy very long because they can't demonstrate functional improvement at any meaningful level.
I think the expectation from our county is very high that we could rehab these patients, and we have tried to show that the natural cause of the disorder is really not in favor of rehabilitation. So we prefer to use a very low pace of rehab for years with different kind of treatments and home visits, and not having patients in a true rehab program. But the expectations from our county is that a lot of these patients should go back to work, as we in all other disorders. But the real truth is that there are very few that go back to work. But some, 5% or so can go back to work from being on sick leave for years. So I think that's not too bad. We expect it to be higher and higher if we could have, we can only meet the patient 11 times a year.
Wow.
Mm.
Wow.
And that means that it's as a whole, I mean, all patients, some patient can go 20 times, then next can only go to 1 time. 11 is a medium. But that's it, that makes it rather difficult to make a good rehab program for them. And we struggle with the same problems that all doctors do with this disorder. Mistrust from the authorities, mistrust from our colleagues, and mistrust from insurances and so on. I don't think I don't know any paradise in the world for ME patients. Is there?
I was beginning to think your place was.
Yeah.
I was
Wow,
very-
then when you're,
Right.
well. We still everyone believes in our patient and give them a good care and so on, but it's a never-ending story. We, for example, the leading neurologist in Stockholm, we have presented a very thorough and good care program, and he said, well, we can't deal with these cultural phenomena anymore. So, and post-COVID is interesting, very interesting. Now they start 3 or 4 post-COVID facilities in Stockholm, but they have a very small staff, and they can only meet very few patients, and they don't know what to do. Either
Are
patients,
push them too hard.
either patients or doctors are very interested in knowing the experience from decades of ME care. They have
Absolutely.
have other thoughts, but we have had some, and that's patients that has their onset with COVID-19, and we're doing fine with those.
I wanted to comment. I told you in my email that Sally and I both have been diagnosed with structural issues and EDS, and I joined Jennifer Brea's Facebook group on pursuing a mechanical diagnosis, and sought expert neurosurgeon evaluation, and actually had a CO to C3 fusion.
Yep.
And I have had improvement in many of my symptoms. And so we're part of a large Facebook group, and we were thrilled to death when your study came out, because those of us in the group were not prepared to meet up with such negative opinions that there might be a structural component, to MECFS. And so we were so glad when your study came out. So the reason I asked you about the measurements was, here in America, the expert EDS neurosurgeons that do these surgeries, they take more than just the CXA angle. And I'm just thinking, probably you've already have a plan. You have all those MRIs and their software you can use to measure. And I would just be really curious what percentage of your patients have craniocervical instability and atlantoaxial instability and even tethered cord syndrome, because we're in the Facebook group, we're seeing several people being diagnosed with all that. So, I see a future study in there for you.
Well, a good guess could be that every 3rd patient, that it could be a good guess. And some of them should undergo surgery. And we have around 25 to 30 patients that has made surgery in Sweden or in Spain or in the United States.
Right.
We're following them up, and it seems to be most of them get immediate good pain relief and so on. it seems to be a bit unstable. Some of the patients relapse. So we following them, and we are having a lot of focus on that, and we try to establish methods that are like cervical blocks and so on, not too invasive, and patient likes them, but they need to make them regularly, and that's a problem.
A lot of the
So,
patients,
but it is a structural problem also.
yes,
It is.
yeah,
And intracranial hypertension is definitely a
yeah,
structural problem.
right. A lot of the patients in the group that don't want to have surgery are pursuing prolotherapy, to tighten the ligaments, and stem cell injections, and some are having some relief. But what we see in the group a lot is that someone will have the fusion and will be getting better, and then they get worse, and it's because the cord, they also have tethered cord, and the cord is stretched more when the head is repositioned, so they go back in and have a tethered cord release, and a lot of them continue to make progress after they have their cord released. Some are actually having their tethered cord released first now, and then having the fusion done after they recover from that. But that seems to be just in the semantics of the Facebook group that I'm in. It seems to happen more in MECFS patients that have been diagnosed with EDS than just the EDS patients alone that don't have ME. But we're seeing that a lot. But a lot of patients don't want to have surgery, so we're hoping, that there can be things to be done earlier on so patients won't have to have, because I mean, my surgery was massive. I don't wish that on anyone, but I'm glad I did it for me. But hopefully it won't be the answer for everyone.
Agree. We should find other methods too, and we will. And we must have surgeons that are using more sophisticated methods and more sophisticated follow-ups. They tend to not follow up patients long enough. So we are trying to get such a cooperation here in Stockholm. We see if it will succeed. We have a lot of projects. Another project is that we are trying to use a hyperbaric oxygen chamber for our patients. So when we have some new treatments for hormone treatments and so on, so there are a lot of things going on. And I think the next step for us will be to try to confirm these findings. We will take cerebrospinal fluid samples and measuring the pressure at the same time that we do the ultrasonic and MRIs, and the samples will be sent for see if there's a neuroinflammation to a very advanced laboratory we have here in Sweden, ME Center in Uppsala. So that is going on. There are a lot of projects.
Are you familiar with the research being done by, it's a Dr. Jonas?
Yeah, he's one of our cooperators. Yes, we're cooperating with him. He will be the one that's analyzing these
cerebral
CSF
spinal fluid.
samples.
Yeah. Oh, I'm glad to hear that. You guys are close together, it looked like, so.
Good.
Relatively.
And we're also applying for fundings via NIH to a cooperation with Harvard University. That we hopefully will have some decision this Christmas. But we're going together with them.
The group at Harvard, is that connected to Open Medicine Foundation?
No, this will be an NIH funding with a research and funding.
Okay.
And the leader in Harvard is Van Elsecker.
Yes. Oh, yes. We're big fans of him.
Good. So we are seeking funding together.
Well, thank you for all of your work. It's so needed. It is so needed. Yes, I have.
I'm sorry. Let me ask this while they're not drilling on my house real quick. If you have these patients that go to Spain and the US and wherever she said for the neck surgery, does your therapy team ever do any post-surgery therapy with these people? And if so, can you describe what their involvement is?
Some of them has been patient with us. They have not been referred by us, but they have been patient with us. And we are following up them like any other patient. And I guess it's a dozen or so.
Are your therapists doing manual therapy with them, like myofascial release or gentle? Because I've done myofascial release since surgery, which has really helped me a lot. Just curious what you're doing with them.
Interesting. We've used that for our pain patients many times after sending some of our staff to United States, but we haven't tried it with ME patients, no. It's a lot to be done. It's a lot to be done.
Do you study mast cell activation syndrome in your patient?
No, we do not. We do not.
It seems to be
I mean,
gaining
we
a lot
are
of-
a private clinic, and all
Right.
our research funds are all our research is internally funded. So anything that goes more or less for being, we try to focus on clinical research. We think it's in treatment research of different kinds. We think that's what's lacking more. The ground research should be made in universities and so on. So we have the patients they do not have. So we can help them, like we just helped Linköping with something. I think it will be a breakthrough study. We will publish very soon with patients and so on. But we think that we ourselves are better at making clinical studies.
Yeah.
Could you
I need to jump off, but I just wanted to say thank you so much for sharing your information. It's wonderful.
Sorry you had trouble, Leanne.
It's okay. I'm here. Bye.
Could you tell me what burned out syndrome is? I'm not familiar with that term.
They call it exhaustion syndrome also. It's a term that originated in the United States among social workers and psychologists and so on that got burned out meeting patients with severe syndromes. In Sweden, it's sort of been a diagnosis in itself for anyone that get very tired from their occupation or their work, and some of them have widespread pain, but it's and some of them have some degree of pain, but they're definitely a group that's differing from chronic pain and from MECFS. I think you would call them mild depression or stress-related syndromes or something like that.
Okay. We would love to have any of your therapists that would like to join our Facebook group. We would love to have them share their experience and what they're doing that's working, so that the other therapists in the group that are still a little hesitant to work with ME patients could gain some confidence and hear some experience. If you want to give them my or Sally's email address, that would be wonderful.
I will do that. We have a very interesting work with a physiotherapist named Berit that's going to work with a new type of pacing, more focused on internal regulation or interoception, as we say. That is, we try to teach the patients to early detect, much earlier detect their internal uprising stress or so they can make a more effective pacing. So that's her topic, and I'm sure she would like to have some connections.
That would be wonderful.
Yeah, we run into the functional issues around heart rate pacing in the, I mean, sure, it's everywhere in the United, not just here in the United States, but relying on heart rate monitors requires money. And when you have a healthcare system that doesn't support you financially, you know, there are lots and lots of people who can't afford the equipment to do that. And so we've been talking about ways to develop interoception.
Good.
You know, so
Good.
having somebody that's already really moved along with that would be awesome to get to talk to them.
Yeah, that would be really good.
I would think that's a key, might be a key factor for not interventional therapy.
Yeah.
To be better knowing your body and react more adequate earlier than
Right.
the crash.
Yeah.
Right.
Yeah. Yeah. Well, this
So
is
it's not
just,
only surgery, knives, and so on. It's also brain and plasticity.
Right.
yeah.
Absolutely.
This is great. Well, thank you so much. This has just been personally fulfilling for me to
Me
get to listen to you and have your inside view of the study you did, but also I got to say, as a person who's lived with this for a really, really long time, just thank you so much for supporting patients like me and like Melinda. And
Yes.
Oh my gosh, the hope that you bring to us just is everything. And
Absolutely.
and please pass that along to your staff.
Yes.
I do.
To them all.
Yes.
Thank you. Bye-bye for this time.
Yep.
Thank you. Bye-bye.
Have a good day.